several research studies, including one for patients with PTEN mutations that I'll talk to you about and support by the PTEN Research Foundation. But I'll make sure I disclose that and let you know when we're talking about the research part. So a quick agenda. I'm going to go over a little bit about PHTS. After all the talks today, I'm sure you already know this, so that's very brief. And then spend some time just introducing everyone to the gastrointestinal system, and then talk about the different GI manifestations of PHTS, and then talk a little bit about endoscopy and what to expect when you or your loved one are coming in for the procedures, because that's one thing I've realized a lot of people don't really get talked to about and don't know what to expect. And I think we can really decrease a lot of concern and anxiety with that. And then I do want to mention the clinical trial that we're very excited to offer. So as you all know, the PTEN hamartoma tumor syndromes are related to germline mutations in PTEN. And then as we're all just discussing, it can lead to a group of clinical manifestations that can be different for everyone, even within the same family. It is autosomal dominant, so it's a 50% risk of being passed down to children. The prevalence is about 1 out of 250,000. Now that is in the Dutch population, where they have really good records for the whole country, and they could give us a pretty good estimate of that. We assume that may be what it is in the United States, but it's a lot harder for us to estimate that. And then the de novo frequency, or new mutations in a person, is likely around 50%. And we just had a good discussion about mosaicism and may explain some of that, but we think a lot of this is just new mutations come up in people, and pretty common, or maybe not uncommon, to be the first one in the family with the PTEN mutation. I always like to go back. So the first description of Cowden's disease was in 1963 in Youngstown, Ohio, which is actually where I'm from. I didn't realize this until I started doing research in Cowden syndrome, but it was kind of a small world for me. And this is basically Youngstown butts up against Pennsylvania, so not too far from the state you guys are in. So there are diagnostic criteria for PHTS. I'm sure you're all aware of this. Mainly have this in for people, and if they're looking at these slides down the road, but this group I'm talking to is well aware of these. But I've had someone describe it as kind of a Chinese menu way to get to a diagnosis clinically, where you need 3 or more from column A major criteria, or 2 major criteria and 3 minor criteria. So it can get pretty complicated. And this is one of the reasons why we always recommend for patients concerned for PTEN mutations or with it to be seen by genetic counselors and centers that are familiar with this, because this can get pretty tricky and be pretty subtle signs that we're looking for to lead to a clinical diagnosis and things to watch for. Now, moving on to the gastrointestinal tract, that starts in the esophagus. I think you guys can see my mouse hopefully here, but the esophagus or swallowing tube goes down into the stomach, and then this kind of long squiggly area here is the small intestine, and then the large intestine, or what we call the colon, is this bigger white tube here, and that's where you do colonoscopies in. All of those places can be affected in patients with PTEN mutations, and we'll kind of go through those one by one. A few definitions before we get into the different manifestations for people. So a polyp, I'm sure most of you have heard of this. Polyps are common. This is why we do colonoscopies in everyone. We used to say at age 50, but now it's age 45 for average risk patients, because we're looking for polyps. And these are little bumps from the flat mucosa or raised lesions that we see at the time of endoscopy. And I'll show you some pictures of that here. This is a polyp, and
sorry, we can't really see your screen. Sorry, we cannot see the slides on the Zoom.
Okay, you can't see it on the Zoom. Let's see.
No, we can't see it yet.
You guys in the room have any idea?
I think we were able to see your slides, Dr. Stanich.
And other virtual attendees were able to as well.
Yes, and others were as well. I'm sorry for the individual who's not able to see. So if you want to share again.
Gotcha. Okay. Can you see it now?
Nope. Not yet.
Not yet.
No, if it's only individual problems, so carry on.
Okay.
There we go.
Now
We
we
can see
can.
it now again.
Okay.
Thank
All
you.
right. No problem. All right. So this is what one potential polyp can look like. This is what we call a pedunculated polyp. And you can see this kind of a stalk of normal tissue coming up. And then the reddish part here is the polyp, and this is an adenoma or a precancerous type polyp. But polyps can also be really subtle. And you could see in this other picture, you could see a lot of little bumps. And this is actually from a patient with a PTEN mutation. And you can see there's just tons of little bumps. And these are all little polyps. Thankfully, in patients with PHTS, these are mainly benign polyps, but you can see how it would be complicated to just go in and remove. You can't remove 20 or 30 or however many polyps you would see in this picture here. So that's just the spectrum of polyps that we would see. Now, colorectal cancer is an invasive malignancy, an adenocarcinoma. This is, looks much different than a polyp, and you could see this is an ugly colon cancer, and you could see that, I don't think it takes a gastroenterologist to look at this and be like, oh, I wouldn't want that in my colon. It looks, red and aggressive, and you could see it's kind of narrowing down the area where the stool would go through. So that's what we're trying our best to avoid, and by finding polyps and removing them, or by thinking about surgery before people develop cancer. But that's a different kind of spectrum of things that you can find in the colon, and that really also applies to the stomach and the small intestine. Now that you've heard about the GI tract and what we can see inside the intestines, I'm going to talk a little bit more specifically about the manifestations in PHTS. So we'll talk about the inclusion in the diagnostic criteria, and then we'll focus on the colon, where we have the most information. Then we'll also talk about the esophagus and the stomach and the small bowel. So in the diagnostic criteria that I introduced earlier, GI hamartomas, which is a specific type of colon polyp that are pretty uncommon in the general population, but are very common in people with PHTS, are one of the major criteria. And you need 3 or more of these, and that includes hamartomas and ganglioneuromas. And we'll talk a little bit more about the different polyp types in a couple slides. But that's one of those major criteria. And like I said, these are very common in people. And then in minor criteria, we include colon cancer and esophageal glycogenic acanthoses, which are bumps in the esophagus. And I've got pictures of that, and we'll talk a little bit more about that as well. But this just shows how the GI tract can lead to a diagnosis of PHTS, and also to an astute clinician who's kind of thinking about it, or a patient who's looking into their own history, can lead to a potential diagnosis of PHTS. Colon polyps are usually asymptomatic. If they're very large, or if there's very many of them, sometimes it can lead to blood loss. Rarely do you see it in the stool, but microscopic blood loss. And so, people who have low blood counts, one of the things we always worry about, do they have colon cancer or colon polyps? And so that's something where, if you have low blood counts, oftentimes you'll get a colonoscopy from your doctor, but usually you don't have any symptoms. Now, there's multiple different types of colon polyps. The one that most of us have heard of and think about, and when you hear about a colon polyp, from you or someone in your family or getting colonoscopies, that is what we call a tubular adenoma. Those are very common in the general population. Right now in the country, about 40% of people getting screening colonoscopies will have an adenoma. These are a precancerous type of polyp. Over 10 or 15 or 20 years, they can turn into cancer. And we know by finding these and removing them, that's how colonoscopies work to save lives and prevent colon cancer. There's another type of polyp called a serrated adenoma. Those are really flat polyps. We see these in about 15% of people. Again, these can turn into cancer. Now, if we look at non-neoplastic or benign polyps, ones that we don't think turn into cancer, that includes hamartomas, which are common in people with PHTS, but are uncommon in everyone else. Inflammatory polyps, which are also common in PHTS and can occur in people with things like Crohn's disease or ulcerative colitis. And then hyperplastic polyps are just benign bumps that don't increase risk, and these are very common. So this is where things can get a little bit tricky. Just because you have a colon polyp, that doesn't tell us much. We need to remove it, send it to the lab, and then the pathologists tell us what type of polyp it is. And this is what GI doctors and endoscopists, people who do endoscopy, are kind of thinking about whenever we remove polyps and get the reports back. Now, initial series of PHTS, when it was first described in the 60s and 70s, did not really report on colon polyps, but that's before we were doing lots of colonoscopies. The current estimate, now that colonoscopy is very common and we know how important it is that more than 90% of PHTS patients will end up having colon polyps. So this is something that's very commonly seen. This is from a study I did, about 7 years ago now, looking at all the reports at that time of people with PTEN mutations who had colonoscopies. And I don't have it underlined here, but you could see 92.5% of the patients had colon polyps. But I think the most important part is that 64% had more than 50 polyps, which is a lot of polyps. So very commonly, patients with PHTS will go in, have a colonoscopy, and have more polyps than we could remove, and can really be concerning for the doctor and the patient. And this is one of the ways in the world of gastroenterology we're looking at picking up more patients with PTEN mutations, is when we say, hey, if you have lots of colon polyps, we need to be thinking about what we call polyposis syndrome. So that's kind of a group of different diagnoses and gene mutations that can cause lots of polyps. But in that needs to be included PTEN. And very commonly now when we do genetic testing with multi-gene panel testing, we know that we need to include all of these. And it's always something that we should be thinking of, and especially when it's a hospital or a health system that sees lots of genetics patients, then they would know to look for these specific types of polyps. But what can get complicated is people with PHTS have all sorts of different type of polyps. So I mentioned hamartomas and ganglioneuromas are in the guidelines as something that's a major criteria for diagnosing, but only 33% of patients and 38% of patients had that type of polyp. But you can see adenomas were common, 40%, hyperplastic and inflammatory polyps were common. And then most people had 2 or 3 different types of polyps, if not more. And we used to think of PHTS as a hamartomatous polyposis syndrome, thinking that the only type of polyps these people had were hamartomas and ganglioneuromas. But now we really know it's a mixed polyposis syndrome. And I tell all the GI doctors I work with and everyone I talk to that if you're seeing lots of different type of polyps, and especially if a few of those are ganglioneuromas or hamartomas, but even if not, we need to be thinking about PHTS, and we need to try and get people diagnosed sooner rather than later based on their GI polyps. Now, I said that data is 7 or 8 years old now, and was looking at papers published even before that. But colon polyposis, there's been some updated reports I just want to show you here. On the left-hand side is a report from the Cleveland Clinic group. So Dr. Ang and her GI colleagues looked at their patients, and you could see at baseline colonoscopy, they found that most patients had 1 to 10 polyps, over 50% had that, but not uncommon, about 1/3 of their patients had over 100 polyps. So this is something where a lot of their patients had lots of colon polyps, and we'll talk about why that's a little bit complicated, and especially if you're at a center that doesn't see a lot of PHTS patients, that can make things complicated and make people uncomfortable knowing what the next step is. On the right-hand side of this slide is a Japanese study that was just very recently published, and they found same results. 98% of their patients with Cowden syndrome who got colonoscopy had colon polyps. They found less that had over 100 polyps, only 5%, but they had 21.6% that had over 50 polyps. And then most of their patients had 1 to 50 polyps. So this is something where, not everyone's going to have, 50 to 100 or more polyps, but a lot of patients with PHTS will have lots of colon polyps. Now, classically, Cowden's or PHTS was not thought to have increased risk for colon cancer, and back then it was Cowden syndrome, and that's the majority of what this data is on, but it should be representative of all PHTS patients. That's because we think hamartomas are benign, and it's very rare that we see a hamartoma turn into cancer. But this can be really hard for pathologists to determine what's a hamartoma, because it's really growth of native cells and native tissue. So they're cells that look like they should be in the colon, they're just kind of disorganized, and it really takes the GI doctor, tell the pathologist that this is a polyp, for them to know that this isn't just a normal area of the colon. So it can be hard for them to tell, what they're dealing with if they just get, a piece of tissue without some of the information from the doc. But in 2010, some new information came out that made us kind of reevaluate the colon cancer risk in PHTS. Now, there are several studies that came out at that time, including, an article from the Cleveland Clinic group that really was the thing that started all of this. But I think these graphs really show this the best, and these are what we call Kaplan-Meier curves. And I'll direct you to the one on the right-hand side, figure 2 here. And this is looking at all of the patients, and this is a European study with PHTS that they were following, and no one had colon cancer until about age 50. Then at age 50, that risk starts to go up. And by the time people are in their 60s, they're seeing an increased risk for colon cancer. Okay, and this is similar to what other groups have seen. And this is telling us that there's not necessarily a young age of colon cancer in patients, but that that risk seems to go up higher than it does for average risk patients. And certainly as people, get to the age around 35 or 40 or 45, we need to start looking in their colon and trying to reduce their risk that's coming of colon cancer. So as I mentioned, there are several studies with similar conclusions. At this point, the estimated lifetime risk is about 9 to 20%. Now, the baseline risk for colon cancer in the United States is about 4.5%. So we think this is somewhere around, 3 to 6 times increased risk. So 6 times increased risk sounds really high, but 10 to 20% risk, it, kind of puts it in a little bit more perspective. 1 or 2 out of 10 people with Cowden syndrome will likely end up with colon cancer. Now, we're hoping with the screening we talk about, we can decrease that risk. But just to kind of, remind everyone, not everyone, not even most people with PHTS will develop colon cancer, but certainly on our radar, something we need to be monitoring for. So what about all these people with hundreds of colon polyps? What happens with them? What do we do about this? The first thing I'll say is I don't think we know enough about this. Unfortunately, hasn't really been a focus of a lot of researchers. And, in the studies telling us what they find in the colon, they don't really say, okay, what's the next step? What do their doctors do? What happens to these patients? So definitely something I think more information will come out in the future, and something I think we need to kind of focus on. And obviously I'm a gastroenterologist, so this is one of my interest areas. And I think I'm sensitive to this because I'm seeing people and trying to direct them, and it'd be nice to give them a little bit better idea of what's coming. From our experience here at Ohio State, and when I was at Mayo Clinic and looked at our data, you should expect to have multiple colonoscopies. So the patients we were following in those centers had about 3 colonoscopies in their lifetime while we were monitoring them. And, the longer you would watch people, the more that they will have. At Mayo Clinic, we found 18% of patients developed colon cancer, and 38% had colon surgery, whether that was from colon cancer or from having multiple polyps, where we felt like we couldn't necessarily watch them safely. So that's a high rate. I think that's probably higher than we would recommend now with some of the new information that we have. But I think it's something we need to realize that, people with PHTS are getting colon surgery that may not need it. And that's why we need to continue to optimize our care of these patients. At Ohio State, again, this was 7 years ago, so we've had lots of patients since then. But at that time, about 1 out of our 5 patients had a colectomy. But the good news is since then, I know none of my Cowden's patients, and I follow about 40 routinely, have needed colon surgery. So I think our numbers would look a lot better that people haven't needed colon surgery since then. But just something to consider when there's lots of colon polyps, then people get nervous about having them in there, especially if we see precancerous type polyps. And why might surgery be needed? As I mentioned, certainly if colon cancer develops, that's an indication for surgery. But then if there's too many polyps to endoscopically remove or monitor, then that's something that gets people into surgery. And every doctor and endoscopist and patient's kind of idea of what's too many to monitor is variable, and there's lots of different things we're thinking about when we make that recommendation. But this is a picture of a colon that after surgery and has kind of been bisected but every little bump there you can see is a polyp. And, as you can imagine, you can't remove all of those with little biopsy forceps. And so, and we can't necessarily always tell which of these is going to potentially turn into cancer. And so if you're not familiar with Cowden syndrome, and if you don't know that overall risk is low, then or if you're nervous about all those polyps, then you may decide to go to surgery instead of needing to monitor all these and risk them developing the cancer. So it's definitely a complicated situation. And again, just a plug for centers that take care of other patients with PHTS that can kind of help patients make the best decisions of what's needed. Now, this is another one of my patients with PHTS. So these are colonoscopy pictures, and on this left-hand picture, there's a little bit bigger polyp. It's kind of the picture's through some water, so I apologize for that. But you can see there's kind of a medium-sized polyp here, and that was in the beginning of the colon. But then the rest of the colon, there's tons of polyps, and you can see in this middle and right-hand side, 10 or 15 or 20 polyps. All of these little bumps are polyps. And you could tell we can't remove all of these polyps. It'd be an 8-hour procedure and not be safe, and just not something that we can do. Now, the thing that makes this complicated is that this large polyp was a tubular adenoma, which is an aggressive type of polyp. Thankfully, the rest of these polyps came back as hamartomas, or benign polyps. But this is where, it can get complicated, where you say, okay, that one polyp was aggressive and it was bigger, so I knew that it was different than the rest of these. But if you're not used to doing this on a regular basis, and no one's perfect, and heaven forbid we missed one, then that's why people get nervous about leaving all these polyps in place. And so that you're going to see how it would be a complicated decision, and certainly something where, at the very least, we want to watch people very closely and do colonoscopy very closely and be ready to act before any polyps turn into cancer. So there's different recommendations for what we do, but thankfully all the experts agree at this point, and everyone has similar recommendations. So we recommend colonoscopy starting at age 35, unless symptoms develop or unless there's a family history of earlier cancer. And so certainly, if there's rectal bleeding or change in the bowel habits, then we'd say, okay, let's do a colonoscopy and make sure we're not missing something out of the norm. Or if there's family history of colon cancer, like the earlier question from one of the people at the conference, we do want to respect that family history. And is it necessarily related to the PTEN mutation in the family? We don't know, but there could be other genes increasing that risk. And so if it's in the family, we respect that and we start early to make sure we're not missing something. And then if everything looks good, or if there's only a few polyps, we recommend every 5 years or more frequently depending on findings. And in a couple slides, I'll kind of tell you my general rule of thumb. There is a recent recent paper came out by the United States Multi-Society Task Force, which is a powerful organization involving the different gastroenterology groups. This just came out within the last couple months, and it was published in all of the big GI journals. And this is a big step forward for the hamartomatous polyposis syndromes, which they included PHTS in there. And they endorse this. So I think this will go a long way towards gastroenterologists having increased recognition of this and helping make sure everything gets covered by insurance and that we're all on the same page. So I was excited to see that this is getting picked up by other guidelines, and hopefully everyone is aware of this by this point. Now, what's my practice? So I start people at 35, as I mentioned. If there's patients with multiple polyps, or if we find precancerous polyps, those adenomatous polyps, I recommend colonoscopy every year. And certainly, we personalize this and we can kind of debate and pick what's best for the patient. But that's my general rule of thumb. If there's only, sparse polyps, just a handful, and I don't have a number in my head, but if I feel like it's something we could watch easily and that I can, look at every single polyp and know, if it's a precancerous one or not, then I may give 3 years. And then if there's no polyps, then I'm comfortable going out to 5 years. But I have to say most of my patients are in that either 1 or 3 year plan, because it's pretty uncommon that we find a PHTS patient with no polyps. Our goal is to remove all polyps if possible, or if not, at least all large polyps, and that should help reduce the risk and help us find any polyps that could potentially turn into cancer. And as I mentioned, if there's high risk adenomas and too many polyps to monitor, we would consider surgery. But as I mentioned, this does not come up very often. And so hopefully, those percentages of patients with Cowden syndrome going to surgery are lower if we look at kind of current practice patterns. Moving on to the stomach and small bowel, much less is known about this. We think similar percentage of patients have gastric or duodenal, which is that first part of the small intestine polyps, but not as many patients with PHCS get upper endoscopy. So that number is still, I would say, a little bit uncertain. Polyps look pretty similar. This is a picture of the stomach. You could see, these little bumps picking up. In the small intestine, they could be much more subtle. So it's a little bit harder to see, but you could just see these kind of little bumps here. And so that is something where if you didn't know that you should be looking for polyps, this is something that could be, missed by a gastroenterologist. So if you had an upper endoscopy like 5 years ago for like heartburn, we may repeat it just because it always can change when you know what you're looking for a little bit more. Now, thankfully, it's very rare to have stomach or small bowel cancer with PHTS. There's just a handful that are reported in the literature, and I would anticipate that it's probably just about the same as average risk, although the latest Cleveland Clinic article sounds like they may be seeing more than they expected to, but the numbers are low, so that's always needs to be taken with a little bit of a grain of salt. Now, there is a report of stomach polyps regressing after therapy of Helicobacter pylori. And what that is a bacteria that's pretty common. It lives in the stomach of about 10 to 15% of people in the United States. In other parts of the world, like Asia and Africa, it's more like 50%. So very common. It can cause inflammation in the stomach, and it is recognized increased risk for stomach cancer and a stomach lymphoma. The good news is only a small fraction of patients with H. pylori will develop cancer. So lots of people have it. Stomach cancer is still rare in the United States. But if we find it, and you could find it through stool or breath testing, we do recommend treatment, and you get treated for with 2 antibiotics and an acid blocking medication. And for all of my patients that have increased risk for stomach cancer or even a potential increased risk for stomach cancer, like in PHCS, I do recommend testing for this and treating it, because I'm looking for every way to, try and reduce that risk as much as possible. And, antibiotics aren't fun to take, but they're overall very low risk. And I think the benefit of treating this outweighs that very low risk. The guidelines at this point don't endorse for or against this, but it is something that I would consider, and I talk to my patients about when I see them. Now, those 2 newer studies that I talked about, what's kind of the latest estimates of stomach and small bowel polyps. In the Cleveland Clinic series, they don't differentiate between stomach and small bowel, but you could see that the majority of their patients have polyps in those areas, and that about 20% have over 100 polyps. So certainly there are people with lots of stomach and small bowel polyps. The Japanese study found 90% of people with stomach polyps and about 90% of people with small bowel polyps. But you can see that the numbers of people getting tested for this are lower. So it's hard to know if all these people had symptoms, or if you tested everyone, if that number would be lower. Be that as it may, we know that stomach and small bowel polyps are common. Thankfully, as I mentioned, they don't usually cause problems, so we don't necessarily go looking for these. But it is something to kind of be aware of, and I'll talk to you about my practice in a slide or 2. Now, glycogenic acanthosis, I mentioned this is one of those minor criteria, and this is also reported to be very common in patients with PTEN mutations. Now, this is tricky because in the general population, we usually don't put this on reports just because it's common to have some of these bumps in the esophagus, and it can be associated with reflux. But in patients with PTEN mutations, it's pretty significant and hard to ignore. And as I mentioned, these are benign little bumps of just kind of overgrowth of the esophageal mucosa. And you could see here's 2 pictures of my patients, and you can see these kind of little white bumps. And, not unusual if you're doing an upper endoscopy on someone with reflux to see a handful, 2 or 3 or 4 of these. But this, where you can just see multiple, even in these pictures, is certainly out of the norm and pretty commonly seen in patients with PTEN mutations. There are some reports that if you've got colon polyps and that you have glycogenic acanthosis, then that means you have Cowden syndrome. I don't know if I would go that far, but it certainly should be a clue that if you have colon polyps and especially hamartomas and glycogenic acanthosis, it needs to be very high on our list of concerns, and that should be an indication for testing. And this is something that we're trying to make GI doctors more aware of to hopefully lead to earlier diagnoses for people. And as I mentioned, they call these esophageal polyps in the Japanese series, but they refer to the glycogenic acanthosis, and you can see how they are little bumps. So I guess that's why they call them polyps, even though that's not usually how we refer to them in the US. But you can see it's very common. They find that in 85% of their patients. So what do I do for upper GI manifestations of PHCS? So there's no guidelines in the National Comprehensive Cancer Network, which is what most of us use. They don't talk about upper endoscopy, nor do they talk about it in the new Multi-Society Task Force. I do recommend non-invasive investigation for H. pylori, so like a stool sample or a breath test. I recommend aggressive evaluation of symptoms, so any reflux or belly pain or low blood counts, we should do it. And at the time of a colonoscopy, I do think it's reasonable to do an upper endoscopy at the same time. We do the upper endoscopy first, we get people sleepy, and then we do the procedure, and it's really, only takes us about 5 minutes. But it's something I at least talk to patients about, would they want to do that or not. I'm going to take one step back. So this may be more relevant for younger people in the audience or people with children with PHCS. But there is a study suggesting that there may be an increased incidence of eosinophilic GI disorders in PHCS. What these are, eosinophils are a type of white blood cell, and you can get kind of reactive inflammatory changes that are more related to allergic diseases than they are, kind of our traditional inflammatory diseases in the GI tract. But it can cause symptoms, and when it involves the esophagus, what we call eosinophilic esophagitis, people can have trouble swallowing and food getting stuck. And if it involves the GI tract, you can have, like the stomach and the small bowel and the colon, you can have diarrhea and pain. And so this is something that we're aware of in the GI community for everyone, but especially in the PHTS patients, it should be higher up on our radar because this is something that may be an increased risk. And the good news is swallowed steroids, so steroids like people take for asthma, but instead of breathing them into your lungs, you swallow them down into your esophagus, is a very effective treatment for this. And sometimes diet changes are enough to treat this. So it is something where if PHCS patients are having symptoms, and especially pediatric patients, this is something that needs to be investigated. All right. So those are the GI manifestations. I think I'm a little bit behind on time, but I'm happy to take questions at the end. But I just want to go through some endoscopy basics. So the upper endoscopy, we look inside the mouth, the esophagus, the stomach, and the beginning of the small intestine. The colonoscopy, we go through the anus, and then we look at the rectum, which is the beginning of the colon, or actually the end of the colon. And then we look at the whole large intestine, and sometimes we could go into the very end of the small intestine. So the two procedures we do the most, what we're missing is the small intestine, but thankfully that area doesn't usually cause too many symptoms, but there are ways to investigate that if we need to. So upper endoscopy, there's no prep. All you have to do is fast the day of the procedure. For the colonoscopy, the worst part is the bowel prep, and that's where you drink a lot of liquid and you have terrible diarrhea and you get cleaned out, but that's how we can see. And I'll show you a picture of why that's so important. And then for the colonoscopy, the 5 days beforehand, we ask you to do a low residue diet. So things that will come out easily, and then have fasting on the day of the procedure. With this, there is sedation, so you will need a driver. So just something to think about when you're booking these is that you will need someone to bring you home because you're going to be sleepy for the procedures. There's two types of sedation. One is called conscious sedation. This is the standard throughout the country and the long time standard. This is like a twilight type sleep. But becoming more common, and I think actually I know everyone in New York and Philadelphia, this is much more common, is what we call monitored anesthesia care, or MAC. That's where you have an anesthesia team give you the medication. It's a deeper sedation. You'll be kind of all the way asleep and won't remember any of it, but still breathing on your own. But the benefit of that is you're not drowsy the rest of the day, and actually people feel better, although we still don't want you to drive or do anything important. That does increase the cost, but this is where your doctor who orders a test will let you know what type of sedation they think is best for you and make sure you pick the one that's best for you. For pediatric procedures, they usually do general anesthesia, which is the breathing tube and all the way asleep. So if you have kids getting scopes, that's the likely plan. So bowel prep, this is the part that's in your hands. So this is a bad bowel prep. This is what we don't want to see. And if everyone does their job right, we don't see this. And then you compare it to a good prep, nice and clean. We could see the walls, and you're able to see this little polyp hiding down here. But you could tell if there's still stool in there, we're never going to see those polyps. So tell everyone, make sure you get your money's worth, make sure you're nice and clean, so we could see what we need to see and give you as long as possible until your next one. And this is just kind of a series of pictures that I've been using for a long time. But this is actually during a procedure. There's some water in there, but some stool in there. Thankfully, this is nice and thin, so we're able to wash it up and clean it up. And then there was a polyp hiding underneath there that we're able to remove. But this just goes to show that you do need to be cleaned out, because these polyps can easily hide if you're not nice and clean. So the new standard is a split dose prep. So what everyone has probably heard people complain about is drinking all of it at one time and 4 liters. But split dose, you drink a little bit the night before, a little bit overnight or in the morning. And not only do you get a better prep, but everyone likes it better. So this shouldn't be as bad as it used to be. And then just so you know, there are different options, and the best prep's the one you can complete and that suits you well. So keep talking with your doctor, find the best option. If you've had a colonoscopy and the prep was terrible, make sure you talk to them about what you can do to make it better for you. So real quick, I think I've got 5 minutes to discuss this, which should be perfect. But a lot of my patients say, okay, we've talked a lot about monitoring, and we're doing colonoscopies, and we're doing renal ultrasounds, and I'm getting tons of mammograms and MRI, but what can we do to potentially prevent cancer? Can we get more aggressive here and kind of do more prevention and just instead of trying to find things early? And so I'm excited to kind of go through this. I don't think there was a talk on rapamycin earlier today, but I apologize if I'm or Serolimus, those are kind of synonymous terms. I apologize if I am overlapping with anyone, but basically PTEN acts on this pathway that ends up down here in mTOR. And so patients with defective PTEN or PTEN mutations end up having more mTOR. But then there's a medication we know that can block mTOR and decrease it. And we started using that in organ transplantation, but then we realized it can be used for some cancer treatments. And then someone had the smart thought, well, would this help people with PTEN mutations? And this is a study in mice, which doesn't tell us too much, but I think these pictures are pretty impressive, where mice with PTEN mutations who don't take the mutation get lots of bumps on their face, get little, what we call palmar papules on their hands, but the mice getting the medication do not develop those and look like cute little normal mice. And then even more exciting, this is another one of those Kaplan-Meier curves, but the mice with the PTEN mutations taking the medication survived a lot longer, and a greater majority of them lived a normal lifespan. And so you say, okay, that works in mice. Would that work in humans? We don't know. But there's a good track record of using Serolimus in other syndromes that are similar. So LAM, I'm not going to say this whole long word here, is a pulmonary condition that has a similar kind of pathway with mutations. And they found that Serolimus helped those patients. There's a recent study published looking at juvenile polyposis of infancy, which is a very, very severe condition where patients have not only PTEN mutations, but also BMPR1 alpha mutations. And you can see here that patients getting the medication did not need colon surgery, where the great majority of patients getting treated without the medication did. And so this is something where we say, okay, it works for these very severe cases. would it potentially work for patients with Cowden syndrome with just lots of polyps? So there was one small trial at the NIH. This was a few years ago now. They looked at 18 patients, so not very many people. But patients on the medication had lots of side effects, but they do report as overall well tolerated, so kind of a lot of mild side effects. People reported they felt better, which is always hard for us to kind of quantify. But what I was excited about is even though it was very short, just 2 months, 2 out of 14 patients had improvement in their GI polyps. Now, in the world of GI, 2 months is like no time at all. Polyps take a long time to grow. They take a long time to go away. So that was pretty exciting that even though it was just 2 out of 14 in 2 months, that's pretty impressive. All right. So as I mentioned, lots of side effects with this medication, but again, overall, we would kind of say well tolerated. So once you get through these and kind of get used to it, people seem to do better. So based on that, I was lucky enough to launch a small trial here at Ohio State. We are looking for 10 subjects to use this medication on who have lots of colon polyps. And we want to do a colonoscopy at the beginning of the study and then take the medication for a year as long as it's tolerated, and then do a colonoscopy at the end of the study and see what differences we see. And so that is something that we have ongoing now. So if you or a loved one or someone you know has a PTEN mutation and they have too many polyps to take them all out at the time of a colonoscopy, you may qualify for the study, and I'd be happy to discuss that further with anyone. And just so you can see, it is kind of intensive lab monitoring and visits, and you have to come here to Columbus, but we're lucky enough to be able to offer reimbursement after each research visit. So I do think it's something where travel would be reasonable for if it's something that you're very interested in. So obviously this is, we're still looking for subjects, happy to talk with anyone. Obviously no arm twisting, and this is something where it takes a special person to participate in medical research, but this is something where I think we can help not only the patients taking the medications, but also future generations of patients with Cowden syndrome. So just want to let everyone know it's exciting that we're doing work in this area, and if anyone's interested, I'm happy to discuss it more. And there's a website called clinicaltrials.gov. That's where all clinical trials are registered. And if you go and search PHCS or Cowden's or PTEN and colonoscopy, this should come up and you could find more information about it. So again, just, we're still enrolling. I appreciate everyone's time and attention. Just a few key points as I wrap up. So GI polyps are very common in PHTS. The colon cancer risk is increased, but not extremely so. So it is something we want to monitor patients for, but most patients will not get colon cancer. We recommend colonoscopy at age 35 and at least every 5 years. That colonoscopy prep is really important. I would add to this key points list, stomach and small bowel polyps are common, but thankfully they don't cause very many problems. But everyone's different, so it's something we need to be mindful of. And then again, consider enrolling in the clinical trial or any clinical trials that are open if you're eligible. And here's my contact information. I'm on Twitter. If that's something that you use, I'm happy to answer any questions. What we can answer over email is limited, but I'm happy to do my best. If anyone has any questions, we can't answer today. And that is all my slides. So I don't, if we can facilitate some questions, I'm happy to answer any questions.
Thank you so much, Dr. Stanich. Yes, and we have some questions in the room and some questions in the chat. So we'll start maybe with some questions in the room.
Two quick questions. What symptoms, if any, would you have us start thinking about an upper endoscopy? My understanding is that colonoscopy is what we were supposed to be doing, and I just had one, but we only did that. So now I'm wondering if I made a mistake.
Yeah, I wouldn't say you made a mistake. So just to clarify, upper endoscopy is not in the guidelines now. So it's not that your doctor, did the wrong thing or that you did the wrong thing. Certainly if you have symptoms, and usually we think about like heartburn or belly pain or trouble absorbing nutrients and diarrhea, or kind of upset stomach, all the kind of things where, if your belly doesn't feel right, that's probably a good reason to get an upper endoscopy, especially if you have PHTS. I think next time you're due for a colonoscopy, and I don't know how old you are, but at some point doing a baseline upper endoscopy to get a sense if there's polyps that we need to follow or that need to be biopsied or to see what we're dealing with, I think is very reasonable. Would I recommend just an upper endoscopy separate from a colonoscopy if you're not having any symptoms? Probably not. I would say, hey, next time you're getting sedated anyways, think about doing an upper endoscopy at that time.
Okay.
Does that make
The
sense?
second, yeah,
Or
no.
does that answer your question?
Second part that is related to my age. I had a ridiculous time getting this approved because I'm 35, which is, significantly younger than what would be considered normal. So I'm wondering if you have suggestions, because the reality is most specialists we see, we have to educate. So do you have suggestions on how to get that information to them or where they could look? Because I had to fight it for months. So I'm just.
Yeah. You had to fight with your insurance or with the doctor,
Yes.
or both?
Insurance.
Insurance. My doctor was very cooperative, but
yeah,
there wasn't a lot that he could find that supported it other than, the foundation stuff.
okay. So fighting with insurance can be tricky. They don't make it easy. I would say that, there's something, the National Comprehensive Cancer Network, or the NCCN, they have a really nice guidelines for hereditary breast, ovarian, and pancreatic syndromes, and that's where the PHTS is included, and it's very clearly spelled out there. So if you can find that, or if your doctor can find that, it should be both of you could do it. That's something where if you show that to the insurance and do either like a peer-to-peer, if you can, that can get it approved. But often it does take kind of either the doc doing a peer-to-peer or the patient appealing and kind of showing that information. But that is where I hope that the US MSTF, that recent paper from the Multi-Society Task Force, will hopefully make that easier, because usually if they endorse it, then the insurance companies have to fall in line. So hopefully next time will be easier, although insurance companies are always looking for ways to make things harder. No offense if anyone out there works for one, I guess, but so no secret, except I would say keep fighting, because it should be covered. And with the caveat that every insurance is different, and so sometimes there's a copay or whatever it is, a deductible. They're always trying to find ways to get you.
Hi, actually, I have like a threefold kind of question. My daughter's been on Serolimus for 9 years. So she's had a lot of polyps and they've been reduced because of the Serolimus. However, she also had an AVM in her stomach, also was reduced. The size of that was reduced also from the Serolimus. But the question was, now that it's reduced in size, can they biopsy in that area? Because they just did a recent biopsy in that area, found metaplasia. So now they're not sure whether to biopsy in that area, because although it seems to have reduced in size at AVM, they're kind of very leery to go around that area. So should they be taking more biopsies in that area? Is it safer now that it's smaller?
That is a really tricky question without being able to look at the pictures and knowing more about what it is. So I'm not usually one to kind of not answer questions like that, but I think that's something that is, yeah, I would really have to see it. So that's
okay.
But I was
Good.
just to say, I'm glad they're thinking about it, and I'm glad, it's exciting for me to hear that the medication is helping, and we're hoping to prove that so more people can use it if it's something that's helpful, or trying to prove that. So that part was exciting, but the kind of the technical aspects, I'd really have to see.
Okay, and then the last question was the colonoscopy, endoscopy, actually it's endoscopy because it's in her stomach that they found the metaplasia. Also because she has the polyps, should that be an increased risk right away? Like, should that be a yearly endoscopy?
So
metaplasia?
So metaplasia in the stomach, and there's multiple different types of metaplasia, and so a lot of it we would just follow like every 3 years, and so I'd really need to kind of know more specifically. So I'm sorry I can't answer that better, but that doesn't necessarily tell me like it needs to be every year. And especially the pediatric gastroenterologists do a lot less procedures than adult gastroenterologists because it's a lot more stressful and other things to think about for kids compared to adults. So I would say the peds GI docs look at things a little bit differently than we do, and rightfully so, because it is much more traumatic for a kid to come in than an adult. So I would just keep talking with the doctors about it, and if you tell them you're worried about it, I'm sure they're happy to kind of discuss the pros and cons with you and help you guys make the best decision. Yeah.
Dr. Stanich, thank you so much for your talk. It was super informative. I have two questions. One for patients considering Serolimus for colon polyps. One, if there is reduction in polyps and improved symptoms, which most definitely many of our patients need because there are significant issues, do they have to remain on this drug forever? Or is it temporary, and then when you come off the drug, do your symptoms come back? So that's question one.
Okay.
And then
go
ahead.
Let me answer that one. So I would say, the first thing is, if you're going to start Serolimus, I think it needs, I would definitely recommend trying to do it in a clinical trial, because we don't even know if it's helpful, and we need to be able to capture that first and say, okay, is this something that is safe and helpful before people just start taking it? Because I think we've learned a lesson, in PHCS, but in multiple areas where, sometimes doctors think things are helpful. And we start looking at it, we understand, maybe we weren't helping people or even hurting people. And so I would say, taking things off label is not the optimal way to do things. So we don't know what the long-term treatment would be with it, because we don't even know if it's a good short-term treatment. That being said, my guess would be that you need to stay on it if that is something. Usually what we found from kind of chemo prevention and other conditions, looking at anti-inflammatory medications to reduce polyps and familial polyposis, that if you come off the medication, the polyps come back.
Okay, great. And we all hear that with the immune system, a lot comes from the gut. And I'm finding that a number of our patients might have immune issues, and many of them have gut issues as well, as simple as low IgA to patients needing to be on IVIG treatments. Are there research studies, or are you looking into that, the correlation between the gut issues and the patient's presentation as far as the immune system is concerned?
There are people looking into that, and there's been some research into things like lymphoid changes in the small intestine and the gut immune system, to look at that. I will say, it's a very complicated topic because it's tied in with gut bacteria and the microbiome, and it gets very complicated very quickly. And so there's a lot of smart people looking at it, not something I'm actively investigating, but I'm hoping they figure it out. And at least in my practice, I think, and again, I'm not sure who was asking the question, but I think that's something that the pediatric docs see more than we see in the adult world, but maybe we're not recognizing as much. But I think there's more to come on that, I guess, is the ultimate answer. I think, but the same with all of GI. So there's a lot of interest in the gut microbiome, and that probably plays into this much more than we think.
I have a question about Serolimus versus Everolimus for GI issues or polyps, because Serolimus is not as well absorbed and bioavailable and quite variable, I guess, from patient to patient, whereas Everolimus seems to be more uniformly absorbed. So would there be an advantage of Serolimus for GI polyps, given that it wouldn't always be systemically taken up, but it would be more locally delivered, or would Everolimus ultimately be better just because it has better systemic absorption?
We don't know. As I kind of mentioned, we don't want to start thinking too well. We don't know that. We don't know if either of them would work the reason we chose Serolimus for our study here is that that's what worked in the mice and that's what worked in that NIH study. Hopefully we can find an mTOR inhibitor that works, and then we'll start finding the best one there. So I just don't, we just have to make sure we don't put the horse before the cart before the horse there. And I think we have to be very careful with that. And we all want to find, there's a lot of exciting, case reports, and, obviously I have the study, so I'm really hopeful it works, but I just want to be kind of very clear and that we need to make sure it works before we start using it broadly. So, but I'm excited that everyone is interested in it. Hopefully you guys, look at the study and hopefully it fits some of you and you want to come out here to Columbus and get enrolled, or, let your network know. But that is kind of my answer there. And then I want to answer one thing quick from the chat. I know, sorry, I hope I'm not going late on someone else's time, but oral polyps are kind of outside of my territory. Usually that's a dermatologist or ear, nose, and throat doctor. Those are different than glycogenic acanthosis, and we don't usually recommend removing those or treating those unless they're really causing problems, because they tend to come back, and some of those treatments can be pretty painful. And so, I have a dermatologist here at Ohio State who I use. I'm sure the people in Philly have someone that they can recommend that they use, but overall, if those aren't causing problems, our general recommendation is kind of leave them alone, because we don't have a good treatment and we can cause some symptoms for something that might not be causing any issues.
If a parent has FAP and PTEN, should the kids who inherited PTEN from that parent get screened earlier in regards to their colon?
So there's someone, is it the same parent has both an APC mutation and FAP?
Yes.
And the kids only have a PTEN mutation?
Yes.
I would that's the benefit of genetic testing, is we could say they don't have, FAP. And so I would just say that again.
They haven't been screened for FAP yet.
Oh, I thought they had genetic testing though.
They did.
And they were negative for the APC mutation, right?
Yes.
Yeah. So they shouldn't have adenomatous polyposis, because they, the genetic testing shows that they're not at risk for that. So technically I would say age 35, but if they came to me and they were 18 and they said, hey, I'm having any sort of belly pain, I would be happy to do their colonoscopy a little bit earlier there. But that's the benefit of genetic testing, is we could kind of clear them from that risk. But that's where we kind of say, and that's where, if you've seen parents go through that and you're concerned, where you can kind of talk a little bit more on a person-to-person basis and have some, personalized care.
And we have one last question.
Doctor, you mentioned the area that isn't reachable via the endoscopy or colonoscopy, and you said there was something on the horizon for that. I was curious to hear what that was.
Well, or not necessarily on the horizon, but we have ways we can look at that. So you can get there, you can look at the small bowel well with specialized CT or MRI scans, so radiologic tests. And then there's something called a video capsule endoscopy, and it's a pill that has video cameras in it, and you swallow it, and it takes 50,000 pictures of the small intestine over the course of 8 to 12 hours. And then we watch that, and it's kind of like you're flying through someone's small bowel. And so you can't direct it, but it takes so many pictures, you see most of the small bowel. And so if there's a reason to go look there, those are the tests we can do. And so those are here very commonly used, but we're not recommending those for screening, because thankfully, small bowel cancer is exceedingly rare in the general population, even rare in PHTS. But let's say there's a reason to go look there. If blood counts are low, or if there's symptoms we can't explain, there's certainly things we could do to look at that area.
Thank you so
Great
much,
question.
Dr. Stanich.
No problem. Well, I'm sorry I can't be there. All right, thank you. Thanks, everyone.
Online, we'll follow up some of those chat questions along with the questions that carried over for Dr. Bauer. So I wanted to introduce our final speaker, Dr. Thomas Fraser. So he's a licensed clinical psychologist. He received his PhD from Case Western in 2004. joined Cleveland Clinic in 2006, and then was the director for their Center for Autism from 2013 to 2017, at which point he was hired as the Chief Scientific Officer for Autism Speech. And is currently a member of the National Board, and he's also a professor of psychology at John Carroll University. We're so excited to have him